Hello, I'm Pat Iyer, and this is Legal Nurse Podcast. Today, we're going to be talking about a problem that costs healthcare and the government billions of dollars, and that is when people have to return to a hospital because of a condition that may have been inadequately treated or incorrectly treated. The government has narrowed down this focus on congestive heart failure, and our guest today is Ruth Pierce, who has extensive experience as a nurse, 37 years as a nurse, and a great deal of clinical experience in the areas of emergency department, critical care, flight nurse, paramedic. She's worked in the area of mechanical circulatory support device and solid organ transplants. She currently works as a field reviewer for a national accreditation company and makes visits to hospitals all over the country to evaluate the quality of care that they are delivering. Ruth, welcome to the show.
Thank you, Pat. Good morning. Thank you for having me.
You're welcome. The topic of congestive heart failure is one, as I mentioned, costs the government and costs our healthcare system a great deal of money. My next door neighbor, and coincidentally, has been in and out of the hospital a couple of times within 30 days for congestive heart failure. And he is getting frustrated by the need to keep going back into the hospital. So give us some context. This condition has been singled out, among others, in looking at readmissions. What are the new guidelines that have been put in place in the United States to try to address the quality of care that we deliver to patients with congestive heart failure?
Yes, congestive heart failure is truly a chronic disease that can be difficult to manage, and the disease is only growing. So we have to, as healthcare professionals, get a handle on how to manage this chronic disease as the patient population is growing. So the main focus for managing heart failure in patients with heart failure is quality of life. You want to have a high quality of life while you're managing this chronic disease. And readmissions are a common problem with heart failure patients. So new guidelines came out in April of 2022, that really talked about current practices on how to manage a heart failure patient. And it really addressed new medications and how you really have to be forward thinking and really aggressive in managing this disease and managing the patients and what will work optimally for that patient and optimize their disease management. So the guidelines came out in 2022. They were a group effort from the American Heart Association, American College of Cardiology, and the Heart Failure Society of America that talked about an agreement on best practices for managing these patients. And it really talks about medication management.
So for our listener, in thinking about when the guidelines come out, clearly they get published, but how do practitioners find out about the guidelines?
A couple ways. So a bedside clinician should know about guidelines through what's typically called best practices in the hospital. So hospitals will have best practices identified in caring for patients. Clinicians specifically focusing on heart disease and specifically heart failure. There are nurses who are certified in heart failure. That means they are up to date, current with guidelines. They are active in professional organizations. They are active in education, ongoing education, that really then they're in tune with what is up and coming, what's the most current information that's out there. Also, physicians are a big source. So it's a really what I call a dual partnership in keeping up with information, both from your clinicians at the bedside as well as providers. Providers have I call it a duty to be up to date with what current practice is on how to best manage their patients, because that's what patients expect. Patients expect to go to a cardiologist and that they are current with what the practice is, current practice, current guidelines on how to manage their disease that they're being treated for. So providers typically are board certified. So if you're board certified in cardiology, if you're board certified in advanced heart failure, those all show that you are having to regularly maintain knowledge and be up to date with professional organizations, as well as continuing education to know that there are things in the pipeline coming out and when to expect them to come out, and then be reviewing them when they come out in articles and papers, and they're in journals, so they're well published.
And when you think about it, Ruth, there's all levels of quality of care in this country, and we're speaking to listeners around the world who struggle with the same issue. The academic teaching centers likely are up to the minute. When my husband goes to his cardiologist, who's part of Johns Hopkins, she can sit there as she's talking to him and she can say, there was a study that was done in Italy with 432 patients that tested the efficacy of this drug in comparison to that drug. She always amazes us because she can quote the research and she is totally tuned in. And then there's the small rural hospital where the family medicine doc might be handling things that a board certified cardiologist would handle. And I'm sure you see this as a challenge when you're making accreditation visits is, yes, it's wonderful to have all of these resources available in the literature, but how does it trickle down to the person who's taking care of the patients?
That's true. That's a good point. And again, even small rural hospitals have access to this information. They might not be as on top of things as an academic facility that is actively involved in clinical practice and clinical trials, but still they are aware. And providers, cardiologists, bedside practitioners, they are also aware. They also have to maintain their license, and their license has a certain number of CMEs attached to that. So they also have to be up to date with what is going on in their environment, whether that be they're up to date minute to minute with what's happening. They might be maybe a little bit behind, but they still will know in the meantime. I will say that most programs take about a year to implement changes in guidelines, especially in protocols in hospitals, whether that be protocols, policies, order sets. Hospitals take a little while, and especially in today's EMR, to make those changes. So you don't expect your practitioners to know immediately what is happening. It'd be nice if they did, but that's not really realistic. So practitioners who are not in an academic facility still want to, and we typically see, are in tune to what's going on, whether that be through journals, whether that be through webinars and meetings. They are still active. You do not practice medicine in a silo. So you are up to date with what's going on, whether it be minute to minute or when you get your monthly journal. So.
And what you're giving us is a great reminder, Ruth, that there is a national standard of care, and there's no pass given to the individuals who are in more remote areas to say, oh, that's okay. You can practice medicine the way that we practiced it 20 years ago or 10 years ago or even 5 years ago. It's your responsibility to stay current and
Yes.
People's lives depend on this. We're not talking with, particularly in congestive heart failure, cardiology, it's not like, you've got an extra organ. If one kidney fails, you've got another one. Only one heart. We got to take care of it.
True. And patients expect that level of care. Patients expect to be treated appropriately and to get the best care possible. So that is an expectation, and providers have to abide by that. And heart disease is a global problem. That is just not something national here in the US. It is globally an issue. So this is something that is being addressed around the world, not just here.
Let's move to what are the implications of not following the new practice guidelines. And I'm thinking in two areas, the clinical implications and then the legal implications. You're a legal nurse consultant. you're familiar with, as many of us in the audience are, of what can happen if you get caught up in a lawsuit as a defendant because you failed to follow the standard of care, and that could be rooted in not staying current or ordering outmoded treatment for a patient, or treatment that's been found to be harmful to the patient. Let's talk about the clinical implications and then the legal implications as it
Sure.
relates to this topic.
So clinically, hospitals are really operating and have been operating on a very narrow margin. And so you're always looking hospital-wide to reduce readmissions, to reduce length of stay. Those have been challenges for hospitals for a very long time. And patient population has changed over time. So how do you manage patients more in the outpatient setting? And that's where heart failure is truly being focused at this point, is how can you reduce readmissions, focus on managing patients in the outpatient setting. So part of that is being up to date with the current guidelines to say, how can we manage these patients medically with medications, adjust the medications, add new medications, include cardiac rehab, and how can you do that in the outpatient setting to reduce coming back to the hospital? So again, managing your inpatient side means having current practices, getting those patients tuned up so they can be managed in the outpatient setting. So that is, of course, then relevant using your current guidelines to reduce that length of stay, to reduce that readmission, and then focus the management of patients in the outpatient setting, and then follow them up closely in that setting. So that is a huge focus for programs and hospitals, is to what can we do to manage them in the clinic, whether it be a diuresis clinic, IV medications, in their office through cardiac rehab, so they don't have to go back in the hospital. So hospital guidelines really focus on that piece. And how can you better manage, and, acuity of patients have changed over the years in hospitals too. And so this is one reason clinical practice guidelines are so important, is to ensure that you can reduce hospital admissions, reduce length of stays, because nobody wants to be in the hospital. Again, looking at quality of life, like your neighbor who keeps having to be readmitted, he doesn't want to do that. He would rather be managed, I'm sure, in a clinic and staying at home than having to be in the hospital for several days every month. So it's important to know where the focus is in managing this patient population. So that's the ultimate importance of ensuring that the care provided in the hospital then ensures that lower length of stay and not having to bounce back to the hospital. Legally, for your legal nurse consultants, it's important to know when you're doing a review for an attorney, to know first, is the patient being provided the care that was appropriate at that time. So typically cases are not current that you're looking at as a review or doing chronology or looking for merit. So you want to ensure that the case timeline falls into whatever the current clinical practice guidelines were at that time. So that's important to know when the guidelines come out. When does that care is expected to be seen in patient management? So if you're seeing a patient, a case, for example, with an attorney that is from 6 months ago, then you would expect for that program, that hospital, that community to be using the current guidelines. If it was a patient from 2019, the case was provided that time period, that's a different set of guidelines. So you need to ensure that you're looking at the standard of care according to the time period and what was available at that time for managing the patient. That's probably the biggest caveat I have for legal nurse consultants.
Yeah, and that's something that can trip up an inexperienced LNC and an inexperienced attorney.
Yes.
And then questions arise. Well, at what point do you expect people to start adopting those guidelines? Do you look at what was current at the time, what was current a year or 2 years before the care that you're evaluating? That can be tricky. It also comes up coincidentally with hospitals' policies and procedures to look at when was the date that was revised? Was it in effect at the time of the care? And it's only fair to judge people by what was current and what was in force and not what was changed afterwards, maybe as a result of the incident that took place. So I'll pull myself back from that path. We'll go back to the main path here for a minute. The clinical practice guidelines that you're discussing, I know that you mentioned they came out of several organizations. Could you give us, again, the names of those organizations, and what is your understanding about how they got developed? What led to the development, and what's the process of getting diverse organizations and opinions together to come up with a consensus? Before we continue with the show, I'd like to share this special announcement with you. How do you prepare your body for a presentation? You look at your audience, a conference room full of attorneys, and your mouth goes dry. How can you speak comfortably in a way that projects confidence if your mouth is dry and the butterflies are rolling in your stomach? I'm Pat Iyer, the author of a book that specifically helps you master presentations to attorneys. The book is Powerful LNC Presentations, How to Get the Case. I've been invited to give presentations to attorneys, LNCs, and paralegals. When you know you're going to be making a presentation, avoid eating a breakfast that includes milk, yogurt, or any other form of dairy. These foods thicken saliva and can also cause sinus congestion. Add these factors to being nervous and dry-mouthed, and you have a scenario for great discomfort. A dry mouth affects your ability to speak. Some people smack their lips to moisten them. When you're speaking into a microphone, the effects can be disastrous. Do I have to explain why breakfast at Taco Bell is not a good idea? The same goes for dinner the night before. Also, watch alcohol consumption the night before you need to give a talk. Hangovers can create disastrous results. Hydrate a day or two ahead of time and keep a bottle or a cup of water or herbal tea by your side. Some people find that a little lemon flavor in the drink makes it more desirable. Watch how much fluids you drink on the day of the presentation and time your water consumption with bathroom breaks. Carbonated beverages have a dehydrating effect. Also, carbonation causes bloating and discomfort. In summary, avoid dairy, highly spiced food, alcohol, and carbonated beverages and stay well hydrated, but not overly so. Powerful LNC Presentations, How to Get the Case, is full of practical recommendations for presenting. Get your copy of my book today at lnc.tips/creating series. Now let's return to the show.
So the guidelines for heart failure came out in April of 2022, and it was a paper put out with collaboration of the American Heart Association, the American College of Cardiology, and then the Heart Failure Society of America. So you will typically see in any of these cardiac guidelines that come out, American Heart Association is always involved. And again, I'm going to sidetrack here for a minute. The American Heart Association, they are truly focused on heart disease and managing heart disease. And so they're very active in ensuring that the care that's provided is current, and they're always doing research. So same with the American College of Cardiology. They are always doing studies, always doing research to say, how can we propel medicine forward? How can we propel the standards of what we are providing for chronic disease management to ensure that these patients are well managed, that we are US and nationally, globally, that we're on top of managing these patients. So trends have occurred over years. And so research is a big proponent, a big piece of this development, and medication research, medication trials. So to see what can we do to even better fine tune these patients in this disease management piece. So it's the research that has evolved over years. So the last clinical practice guidelines that came out, the big set was from 2013. And then there was an update in 2017. And then the current ones that came out in 22. So as you can see, they don't happen frequently. This takes time to develop, to do research, to do studies, to do trials, to then say, okay, this is what we need as an organization, as a group, discuss it and come up with the guidelines. And it takes some time. So, and it is a collaboration. So it's not one entity coming out with these guidelines, but it's a collaboration among several organizations that you'll see, whether that be heart failure, whether it be heart attack, or whether that be chest pain management. It is a collaboration among these groups to come to a consensus to say this is what we all agree on as the standard of care at this point moving forward. And then there's continuing research now and trials and studies to, again, hopefully in 10 years again, we'll have new sets of guidelines. So there's continuous improvement, technology, innovations to help with this process.
I think about what I have seen change from the American Heart Association as a person who started as a staff development director when I finished my master's degree, and I learned how to become a CPR instructor. CPR was done differently in 1979 when I finished my master's program and got my job to how it's done today, all based on looking at outcomes, looking at the research, looking at what sequence of ventilations and compressions is going to be most effective, taking into account the public's unwillingness to do mouth-to-mouth resuscitation on somebody they don't know. It's fascinating to realize that shift is always based on what's working and how can we then provide that education. Just as I think about the need to re-educate CPR instructors, paramedics, EMTs, emergency staff, critical care people, the rapid response teams, the med-surg nurses, the whole gamut of people who could be involved in resuscitation. And then you apply that to congestive heart failure. That's one piece of this. We've got all the cardiologists and the clinical nurse practitioners and all the people involved in the care of individuals with congestive heart failure to re-educate. The consequences we talked about clinically, let's talk about if a cardiology practice is involved in, and really there's two pieces to this. What happens to the accreditation process for a hospital that's not keeping up? And what happens legally in our system when we are looking at the care of a congestive heart failure patient? There's been a bad outcome, and the attorney turns to the legal nurse consultant. So first the accreditation piece, and then the legal consequences.
So there's a couple pieces here. One is CMS. So CMS accredits, certifies hospitals, accredits hospitals, and so you have to have that for Medicare, Medicaid patients. And then hospitals are accredited by several organizations that are out nationally for accreditation. Certification is a next level that says we are going above and beyond. And so for a patient, hospitals have to be accredited by an organization, mostly for financial reasons, and to show a level of care, a level of quality, and expectation to your patients. Certification goes a step further to focus that programs are really going above and beyond and highlight the excellent care that programs provide. So that is something that patients can look for to see if there is a hospital in their community that is certified in cardiac care and heart failure care. It could be also a variety of things, orthopedic and spine. So it's not just cardiac, but there is certification in a variety of different service lines for hospitals. So I can't say that a hospital that doesn't have it doesn't provide good care, because you would expect hospitals today to be current in practices, because there is a level of expectation in caring for a patient in a hospital, that you are following current guidelines. That is a standard of expectation for hospitals. You have sentinel events. You review sentinel events. You learn from your mistakes. And that's how hospitals have evolved over the years, to say there is an expectation that people are not going to get infections in hospital. They are not going to get pressure wounds. They're not going to get bed sores. And so there's an expectation that you as a hospital meet these standards. They're national patient safety standards to ensure the quality of care. And so for a hospital to be certified just says that they are going above and beyond in the quality. So there's a level of quality that you look for in hospitals. But that is I don't know how else to say it besides above and beyond the minimum standard, but the minimum standard still is a level of expectations for patients and families to say that when they go in the hospital, they're going to be provided great care, and they're going to come out of the hospital without harm. Because again, hospitals, patient advocates, patient care providers are always looking to say, how can we reduce harm to our patients? And that's one of the goals while you're in a hospital too, is to not get an infection, not to develop a wound. So those are a couple areas for hospitals accreditation and the care expectations in hospitals. So I'm not sure if that answered your question.
It does. And before you go on, I know I introduced you as a person who works for a national accreditation company as a field reviewer. You go in and look at the care that's being provided in the areas of cardiac care. Have you found a facility that is not in compliance? And if you have, what do they give as a reason as to why they're not current with the standards of care or the clinical practice guidelines?
No, I haven't had that happen. And because, like I said, certification is programs recognizing the great work that they do. And so they have a level of care that they're proud of and they want to highlight. And so they like to show that they're on that journey for excellent care to their patients. So no, we don't typically see that, but the road for improvement has always opportunities. So you're always looking to be better, whether that be in hospital care, in outpatient care, or you personally. You always want to strive to do better. And so these are hospitals that it's an endless journey in healthcare, period, that you want to get closer to that zero harm, because there's been studies that show that, excuse me, that patient providers, patient care providers are always looking to say, how can we be better? How can we ensure that the safety of our patients are high quality patient care, safe events are happening in hospitals? So that's what hospitals are striving for. So nobody wants to have a bad outcome. Nobody wants to have a sentinel event. So hospitals are always learning from that. And so hospitals who are certified are showing that they are really focusing on that piece, that they are truly focusing on the care provided to their patients, that they're saying, yes, we provide great care, and we really want to be able to highlight that and recognize the great work that we do. And so that's what I enjoy, is you do see best practices and sharing of best practices and ensuring, is there a different way of implementing the guidelines? Is there a different way to ensure the patients are compliant? Because patient compliance is a big piece of this. And we'll say that with the new guidelines that have come out, it's heavily focused on medications. And so then how do you ensure your patients are compliant if they're taking 6 or 8 different medications? And they understand that, and to be compliant to get the best outcome. So it's also how do hospitals help each other? Are there new ideas on how to manage this and work with the patients?
And for our listeners who are not in the United States, there's a couple of terms I'd like you to explain. Mm-hmm. First of all, CMS, and then sentinel event.
Mm-hmm. So CMS, or Center of probably not going to say this correctly, Center for Medicare Services, I believe it is, and please don't quote me on that, but it's a government entity for hospitals to have CMS accreditation. And I would have to look a little bit further to get you more details, so I apologize. It's something I've known for years, but probably cannot be very specific in the details. For Sentinel events are a never event, things that you don't want to have happen in your hospital. One that receives a lot of national attention several years ago were when instruments were left inside somebody during a surgical procedure or wrong site surgery. Somebody was supposed to have, say, a left knee arthroscopy, and they did it on the right knee. Those are sentinel events, or considered never events, things you don't want to ever happen in a hospital. And that's what that's termed.
All right. And CMS is, you are right, the Centers for Medicare and Medicaid Services,
Okay.
a governmental agency that controls the reimbursement to hospitals and hospitals who have a large portion of elderly people on Medicare want to make sure that they meet the standards, because if they don't, then they're at risk for losing their flow of money and putting them out of business.
Yeah, if a hospital loses that accreditation, then they're at risk for financially at risk, because hospitals do have a large portion of patients that are Medicare, Medicaid. So yes.
Well, Ruth, I know that based on the information that we shared today, that there are legal nurse consultants who are aware, after listening to you, about the importance of checking for current clinical practice guidelines in care of patients. We've focused on congestive heart failure. These guidelines are available for a variety of chronic illnesses to try to improve the quality of care. And providers are judged based on their adherence to those guidelines. If somebody wanted to talk with you further about this issue, find out more about you and the services you offer, what would be the best way for them to connect with you?
The best way would be through my website, which is windwardcoveconsulting.com. And so that would be my best way. And there's contact information on my website with how to reach me.
Okay. And can you spell that?
Yes. Windward, WINDWARD, Cove, COVE, consulting.com.
All right. Perfect. You've been listening to me, Pat Iyer, and Ruth Pierce talk about congestive heart failure, the new clinical practice guidelines that came out in April 2022. We talked about the way that these guidelines are developed and disseminated, and their importance both clinically and also legally in terms of establishing the standard of care. Ruth, thank you so much for being a guest on Legal Nurse Podcast.
Thank you, Pat. I appreciate the time today.
And thank you who's been watching this program on our YouTube channel at Legal Nurse Business, or listening to it on the audio channels. We also have this podcast available as a transcript. You can go to the show notes for Ruth's program or any of our podcasts and click a button and subscribe to the transcripts. The podcast website is podcast.legalnursebusiness.com. Often I hear that people enjoy the podcast so much that they want to be able to refer to specific points, and it's easier to find it in a transcript than it is to re-listen. So please take advantage of that option, and then you'll begin receiving our weekly e-zines and notices about other programs that we offer. Come back next week for a new show, new topic, new guest, and I'll see you on Legal Nurse Podcast. Coming up next, we're going to focus on a medical diagnosis that strikes terror into the hearts of patients, and that is being diagnosed with cancer. Our guest is a nurse practitioner who is board certified in this area and has extensive knowledge as a practitioner on managing the diagnosis and treatment of cancer. She also has a legal nurse consulting focus in her work. I'd like to introduce to you Lakeisha Falwell, who is our guest, just completed a podcast with me. Lakeisha, what are some of the key points that we covered in your show?
Hi, Pat. Thank you for your time. Today, during my podcast, we discussed various topics as they relate to oncology. We discussed items such as how to improve the quality of life of patients with a cancer diagnosis. We discussed reasons for delay and diagnosis of cancer. And we've discussed different reasons for the failure to diagnose cancer. We also really reviewed the importance of quality of life of patients with a cancer diagnosis.
There was a lot that we covered, and we ended on a note of hope, discussing some of the cancers that are curable today that used to be death sentences. And you'll want to be sure to get an opportunity to listen to Lakeisha's podcast, either on Spotify, Apple Podcasts, and other audio channels, or watch it on our YouTube channel at Legal Nurse Business. Lakeisha Falwell has a lot to share, and it's a program that you will want to pay particular attention to. Cancer touches our lives in so many ways, and you can think of so many stories as you listen to her of people you know who have had a diagnosis of cancer and have gone through treatment that can be excruciating at times. But there is hope, and you'll find out why there's hope by listening to her show. Legal Nurse Podcast and Lakeisha Falwell coming up next.